So hi, good evening. I'm here to perform how to put up with an invasive positive pressure ventilator. So when we hook it up with a ventilator, first and foremost is we always grab it from the department or the clean hold area. Make sure once you're about to get this from the clean hold area. Inspect the ventilator for any defects. Check if it was recently calibrated. Make sure the connections, the tubing are being inserted properly. There are no misappropriate connections to it. And once we're all set, ready to go, we can go ahead towards the emergency room or even patient's room or ICU. And then prior to that, make sure we check the patient's chart, obtain any necessary information that we need to know, such as if there are any details such as the recent physician's order or anything. So moving on, before going to the room, wash, sanitize our hands, of course. Once we go inside to the room to gather the ventilator, make sure we greet the patient. Even though they are unconscious or despite them unconscious, they might have relatives present. Such as, good evening, my name is Ian. So I'm a student from the respiratory care department. So I'm here to give you attach mechanical ventilator. So this would help you breathe even more, and this would aid your breathing. So after that, have to wear appropriate PPE such as gloves. If possible, we can wear goggles, or face shield, a mask, and even a gown. So that way it would help protect ourselves. So while we wear those things, we also have to check the patient's identifier such as the ID band for confirmatory purposes. And also we can move on in trying to ask the patient, make sure that they are unconscious or they might be keep on strangling around or restless. And then we can proceed in doing our pre-assessment. When doing the pre-assessment, make sure we auscultate at all times, listen to the breath sounds. So make sure we're able to hear throughout the lung from the apex to the base, like that. And then while we hear the patient's lung sounds, check the SpO2 level, the heart rate. Check also the patient's color, make sure if they're cyanotic or anything, and then make sure you inspect the AT tube while the patient, one of the RTs or nurses were bagging. Make sure we inspect if it's appropriate, and then after that we can here assemble the ventilator. So with the ventilator, make sure we hook it up here on the patient's bedside. So make sure we secure it by locking the wheels, and then make sure we have the oxygen tubing hook up to hear the click sound, and then the cord should be inserted in this red electrical cord or outlet. The reason why we hook it up in the red electrical outlet is that for cases like there might be shutdown of electricity, so it will switch it up directly with backup battery or anything. So after that, make sure we turn this one on. So this will take a couple of minutes, seconds, about until a minute. So while we assemble, or make sure we inspect also everything, such as if there are any kinks on this flow sensor. And then with this ventilator, because this is a transport ventilator, make sure we inspect the O2 tanks, both of it, if it is complete or if it's full. So that way we don't have to keep on grabbing a different auto tank. So also make sure that we have the suction or vacuum in place on the wall outlet, secured and inserted appropriately. And then with this, make sure we're able to ask the physician if they are present, if what settings they want us to be put up, such as the physician would like us to be on volume control by pressing this in VC. We can either choose which gender, like either male or female. So after that, we can also switch it up on the ideal body weight and the height of the patient. So after that is make sure we set on the controls. So the physician would like us to be on 500 tidal volume. We can dial the knob with a rate of 16, and then also PEEP of 5, so in here. And then the eye time is being ordered at 0.8 seconds. So in the IA ratio, it is 1 to 3.7. And then the FiO2, they want us to be on 60%. And then prior to that, make sure we inspect the alarm limits. So this is a safety range, so that way we will know if there are any specific problems towards the patient, such as the pressure or the PIP, the expiratory minute volume, the frequency or respiratory rate, and the tidal volume. Make sure the respiratory rate is not set on 0, and then tidal volume, as long as it's in the safe range. And then also we can try to check the test or calibration, just for safety purposes, to ensure that both of it, the tightness, if there are no leaks, the flow sensor, this blue and white thing, and also make sure, depending on whichever you want, you can also try to change the loudness, the volume on it, as long as it is audible. The nurses in the nurse station will able to hear, or even you if you're away from the patient's room, and then we can test it out. And then also there are different kinds of things that we can try to put up, but prior to that is we have to turn it on, so we will know with the test lang that it's functional. And then with that, make sure that everything is complete, and then before that is make sure we stand by it and then hook it up to the ET tube. So carefully, while you remove the ET tube, make sure you secure the patient's airway by not having any misconnections on it, and then immediately put the elbow to the patient and start the ventilator. So in here, with the ventilator, we will notice some waveforms. We can either pause, sorry about that, that one, either depending whichever you want to check the mean airway pressure. We can also try to check the graphics, whichever you want, by having a lung to know, depending if whichever you're comfortable with. And then with this, make sure you're secured. And then once you inserted the mechanical ventilator in the patient's ET tube, make sure you assess again, listen to the breath sounds, because it might lead to disconnections with the ET tube. And then after that is we also have here a inline suctioning. So the inline suctioning is very important for touching during a mechanical ventilator, because the reason why there is an inline suction is we have to prevent the patient to have any ventilator associated pneumonia, because the inline suction is being secured by this sheet, as we can see. So you have to make sure that it's inserted appropriately to the patient. Sorry about that. Okay, and hook it up. So with this, make sure that we have the suction bottle in place, and then there's a connecting tube. I'm sorry that we don't have that connecting tube available right now, but we just have to assume it is in place, and then it should be connected in this one. And then while we hook it up, make sure we turn it on, and then make sure we're able to set the appropriate pressure of -100 to -120, especially for adults. And then if we want to suction it up, make sure we hyperoxygenate. In here we can press it, so you can see in for 2 minutes, depending whichever model or whichever you're comfortable with, or you can try to manually switch it up to 100%. Just make sure that you know what's the original setting for the patient. So for example, you set it up on 100%. So in here, make sure while you suction it up, be able to hold the ET tube by other hand, while the other one is being inserted it in here. So while suctioning the patient until we feel that first resistance, or if the patient does cough, we try to withdraw a little bit, but while we withdraw it, we have to press this button and suction it like that. And then we will take note of its consistency, the color, or even the thickness. Take note of it and chart what's the secretions of the patient. And then usually, while we do suctioning, most importantly, we should not do it more than 10 seconds. And then while doing multiple attempts, it should not be more than 3 attempts, which is pretty important, because we have to prevent the patient from having trauma in their airways, and also from any irritation if we keep on suctioning. So moving on, we did our suctioning, we already cleared the patient's lungs. So in here, we're gonna perform a cough checks. So the cough checks there are different techniques, such as the minimal leak and the minimal occluding technique. So with the minimal leak technique, make sure we have a three-way stopcock, and then we have a syringe, and then make sure we auscultate the patient's neck, and then all we have to hear is that gurgling sound. So first, put this on the lateral on the neck of the patient. This one to the syringe should be inserted, and then first is you have to kind of withdraw not too much of air carefully until such time you hear that gurgling sound. That is your minimal leak technique. So usually with a three-way stopcock, there's a manometer in place. So with the minimal leak technique, you will know what's the appropriate pressure. So once you hear that minimal leak technique, immediately, while still on the stethoscope, immediately try to push the syringe forward until that gurgling sound is gone, and then take note of the pressure of the manometer. Another thing to note in the cuff cares is that while we do the cuff cares, make sure we also have this cuff leader. So while we do the cuff leader, carefully insert this one in here, and then we can try to adjust by pressing this balloon carefully, not to try to press it immediately because it might inhibit the gag reflex of the patient. Just carefully, and then while we adjust, if ever that the cuff pressure is low or too much, we can try to adjust it, or if it's too much, while you want to lessen it from the amount of pressure, you have to adjust it with this red button until you're able to reach the safety range of 20 to 30 centimeters of water. The reason why we always do a cuff checks is that we make sure that we're able to maintain a seal on the lower airway to prevent the patient from having any aspiration, which is pretty important in our vent checks. So after that, we have to set this on the side. Make sure we're able to take note. Make sure we also inspect again the ET tube for any misconnections, just to be sure. So after that is we can try to do our oral cares. So with the oral cares, there are different varieties on it. So first is we have here the Yonker. So with the Yonker, it should be attached with this adapter, and then with this adapter, it should be inserted it with this suction connecting tube towards there. And then first is we have to remove the sheath, and then with this is we have to try to suction it with ample amount of sterile water to make sure that it's functional. So while we're about to suction this one, make sure we suction towards the patient's airway, on the gums, on the tongue, on the sides, and then because this ET tube has an ET holder, make sure we try to shift the ET tube from one side to the other. The reason why we did do that is we have to maintain the patient's mouth or oral not to have any pressure source or any irritations. And then while we suction it up, make sure we will not inhibit too much until the gag reflex. And then also an important thing is that with the suctioning part, make sure we try to clean it on the sides of the ET tube, so that we try to clean it up, especially their secretions will stick. And then after that, we have to set this on the side. This one should not be removed, and then we can proceed with the other one, which is the oral suction swab. With a suction swab, there's an oral debriding agent, so make sure it's not too clump. And then there's also a connecting tube where, because this oral suction swab, we can try to suction it up. Still, when we try to put this to the patient's airway, move one side from the other as much as we can to prevent any sores. Clean the sides, but not to push too deeply. And then try to clean the gums. Try to inspect if there's any minimal secretions. We can try to suction it up, because we can suction it because of this hole. So once everything is all good, based on your assessment, remove this and dispose immediately. And then there's the other thing. We have to do a moisturizing agent. So usually when we do oral cares, it is done every 2 hours. Especially with the toothbrush. With the toothbrush, we will usually do it every 12 hours. So this is the moisturizing agent. We have to cover it up, but not too plump at all. And then make sure to dispose it. And then this one should be inserted carefully. Make sure we also have to change it up from one side to the other. make sure everything is being moisturized on the sides, and then most importantly on the lips to prevent any dryness. And then this one should be disposed. So after that, as what I've said, we can do toothbrush every 12 hours. We will proceed in giving a nebulization. With the nebulization treatment, make sure we check the patient's chart for any pertinent orders. If what's the medication the doctor would like, what's the frequency. And then with the medication, with a small volume nebulizer, we have an attachment on the side in here. Make sure it's being secured. And then most hospitals, depending the policy, most of them this is already built in on the tubing. For some, they want to remove it right after. Make sure you put this on the patient's airway, near to it, and then make sure you position it upright. We can try to change it up by removing the tubing, and then position the arm like this. Make sure we position this in an upright position because we want to have the patient receiving adequate mist from the medication. We should prevent the position of this from having sideways or even downwards like that. And then while we give medication, all we have to do is press this button with the green light, and then we will hear that hissing sound. Once you're all done with this, you will turn this one off, pressing it again. And then another important thing that I would like to tell also is the nebulization treatment is, for example, this patient was being put up on HME. For assuming this blue flow sensor is the HME, just for example, we have to go back first. So for example, the physician would like to give nebulization treatment and this is an HME. All we have to do is replace this one. Like that. Replace it with a nebulization kit. The reason why we exchange it for a while is because we want the medication not to stick on the filter or not to be clumped, because if you wanted it to give with the HME and the nebulization treatment, the medication would lead to be stick or being clumped in the HME. And then once you're all done giving medication, remove this and then return the HME. That's if you're using an HME patient. And then also another thing to note with the nebulization treatment, because this one is a single limb, some ventilators have a double limb with a Y connector piece. The other one has been connected towards the humidifier, that is the inspiratory side, and then the other one is connected on the side, which is on the expiratory side. So usually, if we want to be giving nebulization treatment with a double limb, make sure we try to inspect carefully that we hook it up the nebulization kit on the inspiratory side. Make sure we inspect it at all times. So that is one of the important things with the nebulization treatment. So once you're all done with this, so for sure the patient's secretions are being loosened up. So make sure we try to suction it again. Make sure we hyperoxygenate again the patient, and then suction with the inline suctioning, not more than 3 attempts, and then not more than 10 seconds. So that way we prevent the patient from having any pneumonia. So after that, in here we're gonna do another breathing treatment. So in here is a meter dose inhaler. So with the meter dose inhaler, so make sure we always try to check the chart for any orders, what specifically medication the doctor would like. So in here, make sure we try to shake it up, and then while we give medication to this, it should coincide with the inspiration. Usually we have to give it on the proximal side of the connecting tube. So there's a connecting tube usually here, which is very good to give medication towards directly to the airway. So make sure we try to remove this carefully and then insert it up, and then while try to coincide it with the patient's inspiration, and then press or actuate it. So while you actuate it, try to give patient about 30 seconds until a minute, until you give another puff, depending if the patient or if the physician would like the patient to be given with at least 2 puffs. So once you're all done with this, make sure you set this on the side, and then all of this, what we're trying to do, should be disposed except for the Youngker. For the neb kit, we still need to give, and also with the cuff later. And then once you're all done with it, make sure you try to inspect the ventilator for the parameters. And then by the way, with the parameters, as we can see here on the alarm limits, so in here in the middle is the spontaneous breathing, or what's the monitor of the patient, as we can see here on the monitoring side. Everything. So make sure we inspect again the patient, try to listen again to the breath sounds, post-assessment, double check the ET level if still in the safe appropriate leak level. Make sure we check the vital signs of the patient, the SpO2, the heart rate, and also as much as we can, make sure this is in place, which is more accessible together with the mask. For some reasons that the patient might self-extubate or accidentally extubated, so we immediately bag the patient prior to the intubation, which is pretty important. So inspect everything, make sure this one is secured and locked, and then make sure we try to check if the connector is being hooked up on the red outlet. And then in the ventilator side, make sure we screen lock it. The reason why we screen lock it is in here, we prevent from any persons to inappropriately press these settings for safety purposes. Make sure this one is secured at all times so that this will not fall down to the patient's head. And then double check everything, the suction, turn it off. And then make sure everything is secured. Once you did your assessment, like the breath sound, you already did your cuff checks, the oral cares, and then you did your suctioning. Once you're all done with those, remove the PPE. Wash your hands, especially you already removed your gown, goggles, and mask. Wash your hands. Once you're about to go outside, you already did your vent checks with a flow sheet, which is done usually every 2 hours. Once you go outside, document everything that you're trying to do. Communicate with the nurse in charge, or if the charge nurse present. If the physician is present, that would be very much better. Try to communicate the physician what's your observation and what are your recommendations are. And once you're all done, and we're good.